Good afternoon and welcome to our Family Voice webinar this afternoon. I'm Andrew McColl. I'm the Queensland Director of FamilyVoice, and I'm joined today by Professor Patrick Parkinson. Professor Parkinson has been a member of the New South Wales Child Protection Council and served from 2004 to 2007 as the chairperson of the Family Law Council. He was president of the International Society of Family Law from 2011 to 2014 and Dean of Law at the T.C. Burns School of Law from 2018 to 2021. Professor Parkinson is the Executive Director of a new Christian organisation, Publica. You can find them at www.publica.org.au. And Publica is interested in strengthening families and communities in a post-Christian society. He also works with churches on child protection and religious freedom issues. Good afternoon, Professor Parkinson.
Good afternoon, Andrew.
I'm also joined, I believe, by my colleague in New South Wales, Graeme Mitchell, who is assisting me with some questions this afternoon.
Yes.
So, Professor Parkinson, Dr. Dylan Wilson wrote in January in relation to the Queensland Review last year that, and I quote, "One of the biggest disappointments in the area of assessment and treatments of gender-distressed children is the propensity for paediatricians as a profession to accept the superficial nature of what we have been told about the assessments and treatments that are given to children, how they come about, the diagnoses that are given, and the strength of the evidence for the practice. We're often told that everything is fine and our profession has accepted. It seems this Queensland Review is no exception. However, a detailed look at the review reveals it to be just like everything else related to gender medicine, flawed, superficial, and contradictory. Moreover, this review is incredibly weak," unquote. How is it, Professor Parkinson, that the ideology of transgender, even with doctors who are, of course, scientists, has subverted the fundamentals of science and biology?
Well, Andrew, it's a big question. First of all, let me just say that Dylan Wilson, who I know very, very, very well, who's a paediatrician in Queensland, was referring to the 2024 review under the previous Labour government,
Right.
which reviewed the conduct of the Children's Gender Service, but they were instructed not to look at the efficacy of the treatment. So the whole debate, which has been there for all over the world in this treatment, they were asked not to look at. So it was a very flawed review. The present Queensland government has now instituted a new review, and that's ongoing, looking carefully at the evidence. But coming to your question, it might help everybody if I explained a little bit about how the whole area has moved, because essentially what's happened is we've moved from a medical diagnosis through to a human rights approach. And I think when Dylan Wilson says the paediatricians don't understand what's going on, that's what they don't understand what is happening. That paediatricians may well think that what's being practiced is what used to be practiced, which was a careful evaluation of whether a child, a young person, or even an adult had gender dysphoria. But that's not what's happening now. So if I can just to explain that.
Sure.
Always known of people who have been transgender, mostly men, mostly born male, and they've come to a point in their lives, often in midlife, where they feel they can no longer live with their body as male, and they transition to, as best they can, to a female identity. People may remember Caitlin McGregor, who was a senior army officer and made that transition and did so with great sympathy from the public and from people like Tony Abbott, who he had known. So this is a well-known phenomenon, and it's certainly rare, but mostly it was men. About 3 to 5 times as many males as females had this problem. Is it genetic? Is it hormonal? Nobody really knows. But it's certainly been there. And it used to be called gender identity disorder. Now, the push which has come from the transgender movement has been to move away from a medical model. They didn't like the term gender identity disorder because that implied that being transgender was somehow a mental illness. And so in 2013, they got changes made to the major sort of diagnostic manual for mental health professionals called the DSM, and they called it gender dysphoria. And the argument was being transgender is not a problem. This distress you have about that gender is the problem. And so what the psychiatrists and clinicians are treating is the distress, not the fact that a man feels like he should be a woman or vice versa. Now, the test of gender dysphoria has always been, still is, distress, clinically significant distress, that they're so troubled by their difficulties that they may be profoundly depressed, could even be suicidal, and therefore treatment is justified. The problem is that as more and more people came out as transgenders, more and more teenage girls came to these clinics, they weren't distressed. They weren't distressed. They were fine about their gender identity. They weren't troubled by it. They just said, well, I know I'm a female, but I actually feel like I'm a boy. They weren't distressed. And so they didn't meet the diagnostic criteria. Well, if you don't meet the diagnostic criteria, you shouldn't be treating them.
Right.
But they then moved the goalposts again and said, no, we'll call it gender incongruence. And in another manual of diseases called the International Classification of Diseases, the new edition came out and said, well, no, this is an issue of sexual health. It's not a disorder at all. But it's shifted even further now. And what is really going on in a lot of these clinics is a human rights approach. That is, this person believes that they are transgender or they're non-binary, which is a completely new concept, really. They deserve to have whatever treatment they want to have. And so the medical profession is still thinking in many cases, oh, well, they're going through a proper diagnostic process, an exhaustive diagnostic process of identifying gender dysphoria, seeing where it's come from, exploring what's happened in this person's life, making sure this is the right path for them, exhaustive, careful diagnostic approach. But what's really happening in a number of these gender clinics is essentially an affirmation approach. This child, this young person, this adult believes they're transgender, therefore they are, therefore they should get the treatment that they want. And this has all happened in about 15 years.
Right. Graeme, are you there?
Yes, I'm ready to ask the next question. We ready to move on?
Yes, sir.
And Professor, this is also from Dr. Dylan Wilson, a continuation of the report that he prepared. And he wrote in that report, the Queensland evaluation is implicit throughout that Queensland Children's Gender Service is under the auspices of Child and Youth Mental Health Services. It is a subsidiary, a mental health service. One of the recommendations is that it strengthens its fertility preservation strategies. Consider this more deeply for 1 second. Why does a mental health service even need a fertility preservation service? What realms of normality have we reached where this is even a thing? The only reason the QCGS needs better fertility preservation strategies is because the treatment pathways render the children sterile and infertile. Is this the most damning aspect of the so-called trans treatments, in your opinion?
Graeme, there are so many damning aspects. Where do I start? But let me pick up with what Dylan is saying here. This starts off as a mental health service. And indeed, in England, the Tavistock Clinic, of which many of you may have heard, was a mental health service in a very, very prestigious mental health clinic, the Tavistock. But as this new mode of treatment emerged to be able to use puberty blockers and then cross-sex hormones to change the sex traits of somebody, there was this big push away from ever treating it as a mental health issue. What I was saying before, this is a human rights issue. Being transgender is not a problem. There are cis people, there are trans people, it's not a problem. And so we've shifted from a mental health model to a physical treatment model. And then the final sort of change in all of this, which is so radical, is actually banning psychotherapeutic treatment. The very thing that we offered for all those years as a response to a mental health disorder, a mental health problem anyway, is now, certainly in Victoria, banned as conversion therapy. So this is the big shift. And the treatment, certainly for young people, has a very real risk of infertility. When I say very real risk, let me explain what I mean. It depends whether we're talking about boys or girls. With boys, if they are put on puberty blockers, as they have been, what's called Tanner stage 2, it's when puberty just begins to be visible in a boy. If the puberty is blocked at that point, they will never have an orgasm, according to one leading doctor, because essentially they're locked in to a child's penis, a child's scrotum. Sorry to be specific to people, but that's what's going on when you block it that early. With girls, you've got immature eggs. And so the very real likelihood is if you block puberty that young and then you go into cross-sex hormones, chances are that both males and females will be infertile, and there will be a real disruption, at least, to their sexual pleasure, particularly for boys. Now, not everybody takes the decision to go on puberty blockers so young, and it's quite possible for a girl to fall pregnant. And indeed they do, having gone through puberty and then taken cross-sex hormones. And what they've done is they've gone off cross-sex hormones later because they want to have a baby. And so you get these very strange cases of people identifying as male with a beard and then pregnant because they've gone off the testosterone. And so testosterone almost certainly significantly impairs fertility, but may not destroy it. But you asked me, is this the worst aspect? I don't think it is. I think the worst aspect, and I'm just focusing on children now, children and young people, because that's where my expertise is. That's where, as a child protection expert, I became so concerned about this. We have known for years that the majority of children who have gone to gender clinics, famous gender clinics, one in Amsterdam, one in Toronto, they're probably the two leaders in the world, most of those kids would resolve their gender dysphoria once they got through puberty. In other words, they may present to a gender clinic at the age of 7 or 8 or 9, but if you work with them, work with the parents, take a flexible approach, let them wear a dress if that's what they want to do, but don't interrupt puberty, then most of them will resolve their difficulties. And the great majority of those who resolve their difficulties will grow up to be gay or lesbian adults. So you see that the gender incongruence is like a precursor to a same-sex orientation. And this has been known for years. Every single study has shown the same thing. The percentages vary. I think the smallest percentage is around 65% of the kids resolved their issues through puberty, some didn't, up to about 85%. But this has just been wiped out as if it never happened. And the whole assumption of puberty blockers and cross-sex hormones is that once trans, always trans, that you can't resolve it. If we block puberty, you can pass much more easily as the other sex as an adult. But this is, to me, the biggest scandal, is that they have just ignored those studies. Now, they claim, well, they were older studies, the definition of gender dysphoria was different, all that's true. But every single study has shown the same thing. So we have a situation where if we just left kids with good therapeutic support, didn't intervene, didn't allow them to change their names and pronouns, just allowed them to develop and grow, there's a very good chance that as the hormones hit through puberty, that they will resolve their difficulties, and there's no need to engage in life-changing medical interventions which leave them needing medical support for the rest of their lives. That to me is the biggest scandal.
For those viewers who have a question to put to Professor Parkinson, we'll be taking those questions in the latter part of our hour today. So if you want to just click on either on your chat or your Q&A button at the bottom of your computer, you can type those in, and my colleague Peter will be able to moderate those and put them back to Professor Parkinson a little later. Professor, the Royal Children's Hospital in Melbourne appears to have been quietly shifting its goalposts over time after claiming that its transgender treatments had support from the highest levels, unquote. Does this illustrate how supposed medical professionalism can come under pressure and succumb to unproven fads without a biological basis?
Well, it does. And of course, there's a long history in medicine of this. This is not the first time the medical profession has been taken over with a fad. But what happens is that, and this happens in every area of life, I think, that a groupthink begins to take hold, and all the right-thinking people think the same way, and people go along with that. And once you have adopted that fad, it's quite hard then to get off it and say, no, we were completely wrong. I think this is the issue the Royal Children's Hospital has got down in Melbourne. It has been the leader in this field in Australia, and it's had enormous support from the Victorian government. The Victorian government has, more than any other state in Australia by a country mile, embedded transgender beliefs into its education system. And so you've got kids, 6-7-year-old kids, being taught that you can change your sex and that you may be trans and this sort of thing, and posters glorifying all of this. And then the Royal Children's Hospital has been the flagship. That's been the pride and joy of the Victorian Government Health Service.
Right.
So it's very hard for them to now climb down from that and recognize and acknowledge that actually these treatments have a very, very weak evidential basis. And they haven't done so yet. They are still digging their heels in, or I would say putting their heads in the sand on this issue.
Thank you, Professor. We'll move now to a New South Wales report by the Sex Institute review in 2023-24, which claimed that the evidence for blockers was safe, effective, and reversible. Though they had access to independent reviews in Finland, Florida, and Sweden that found otherwise. But that same institute is dependent on the New South Wales Ministry of Health for funding. What does that tell us about the wisdom of taking advice from taxpayer-funded departments that has an established position on such an issue?
Well, it is certainly a problem. Let me explain a little bit about puberty blockers. And puberty blockers are safe, effective, and reversible. That is true. But it's true for children who experience what's called precocious puberty. So the idea of blocking puberty emerged as a treatment option for little girls who might start their periods at 7 or 8, little boys who might begin their puberty way before the normal time. And of course, developmentally, you don't want a little girl having to deal with menstruation at 8 years old. She should be playing with her friends in the primary school playground, not worrying about such things. And so puberty blockers were a very clever, very safe way of just postponing that puberty until a normal age at which children would be expected to go through puberty as a female or as a male, respectively. I've spoken to a leading endocrinologist, a pediatric endocrinologist about this. I remember I'm a lawyer, so take all my explanations of medicine with a pinch of salt. But I understand that it's quite safe to block puberty for up to 3 years. So if you had an 8-year-old girl, you might use puberty blockers until they're about 11. And then you would let normal puberty commence as it should, and she would go through a normal puberty. So that's what we mean when we said safe, effective, and reversible. But what happened is that these same puberty blockers were used to block puberty at the normal age when kids should be going through it. And that's a very important developmental stage where the hormones have effects on the brain, when all sorts of things are happening in the body as they should be, and you're artificially interrupting that process. And one of the big concerns is about brain development, because there's some evidence, it's still very patchy, but some evidence that blocking puberty at 12, 13, 14 years old, at a time when the brain should be developing with the input of hormones, could actually be causing significant harm to the brain. There's also significant harm to bone density, which then has long-term implications for osteoporosis. So puberty blockers used for gender incongruent children, no evidence that that was safe, effective, and reversible when these things were introduced. We know from a few cases that the harm to bone density, for example, is a serious issue, and they have to monitor that very, very carefully. The other thing is this, that puberty blockers have been used for up to 5 years. So kid is at Tanner stage 2 at the age of 11, say, and then you want to wait until they're 16 to have cross-sex hormones because they need to be mature enough to make that decision for themselves, at least understand it. So you may have 5 years when you're blocking puberty, and there's no research that I know of that says that's safe or effective. And as for the reversible, well, what we see is, and I know this is another question coming, that 95 to 98% of the kids go on to cross-sex hormones. So it doesn't appear to be psychologically reversible once you place a child on this pathway, and particularly if they change their name and they enroll in school as the other sex. You know, a boy starts high school as a girl and she's called Sarah. That locks them into a real prison. How do you reverse that? So much of their identity and their social group is caught up with them being female. So that's what is the issue when you talk about puberty blockers being safe, effective, and reversible. Now, the Sachs Institute is interesting because it is, I think, the only study in the world which has reached the conclusion that everything's okay with this treatment protocol. Are New South Wales children somehow different from every other child on Earth? I don't know. But they were looking at the same body of research as everybody else. They just reached completely different conclusions. But here's the inside story, I think, on this. The Sachs Institute does evidence studies for health in particular. And they were commissioned to do a study back in 2020. And the Department of Health was in New South Wales, wanting to roll out a big new pediatric transition program. They were wanting to avoid the cautious approach that Westmead Hospital had been taking very sensibly. And the Sachs Institute report back in 2020 endorsed that and gave them the sort of validity, if you like, gave them the permission to say, this is evidence-based, we can roll out pediatric gender treatment. And that report came out a few months before the very first major government review in England, which was called the NICE review, National Institute of Clinical Excellence. It's NICE for short. And this was a thorough review back in 2020 of puberty blockers and then of cross-sex hormones, saying the evidence base was very weak. And every single review since, apart from Sachs, seems to have come to that conclusion as well. Now, they're asked in 2023 to 24 to update their report. And I think it may have just been too difficult for them to say, oh, we got it wrong in 2020. And so if you read the full report, what you find is they say throughout the report things like, oh, the evidence base is very weak, and oh, you've got to treat this all with great caution. That's not what the press release said. Okay. So, and the summary didn't say, oh, these studies are very weak, the samples are small, the researchers may have been biased, all these problems. But every other major review has looked at all those issues and has looked at the sample size, looked at the evidence base, looked carefully at the quality of the studies, and come to the opposite conclusion to the Sachs Institute. So, look, you asked me, can we trust reviews commissioned by government departments? Well, I certainly understand what you're saying. The Department of Health was hell-bent, I think, on expanding paediatric gender treatment in New South Wales. There had been a program at Westmead, but they were very cautious, and sensibly so. And they wanted to expand it and to respond to the LGBT community. And conveniently, if you like, they got that support from the Sachs Institute. And that's always a danger. Bias in research is a huge problem. But I don't think we should just distrust every government department. I mean, the National Health Service instituted the CAS review. It was the Finnish government which instituted the review in Finland, and then similarly in Sweden. So they have done a proper job at arm's length from the government. And so much depends on the quality of the researchers. I suspect, without knowing, that the Sachs Institute people were not terribly well qualified. It was a Monash group. But also the integrity of the researchers in being rigorous about how they evaluate different studies. And that didn't happen with Sachs, as far as I can see.
Thank you.
You wrote back in April that about 95 to 98% of children on puberty blockers go on to take cross-sex hormones.
Yeah.
So it would seem that they operate as a platform to get onto a trans train that hurtles inexorably to its destination, irreversible transformation of the body that some will later regret. So, unquote. So what do we know now? What do we know now about a large proportion of these children?
We know a lot and we don't know much. So what do we know a lot about? We know a lot about who's coming to gender clinics now as young people. And I said to you at the beginning that this problem is one we've always known, and which I have enormous sympathy for the people who suffer from gender dysphoria. It must be a terrible burden on their lives. We've always known that was a problem, but it was mostly a male problem. 3 to 5 times as many males as females. Now, all over the world, the gender clinics are seeing about 70% female teenagers. So that's a big issue. Why has the gender mix reversed in such an extraordinary way? If you believe that there's some hormonal genetic explanation, and I don't know there is, but if you do believe that, you would think there'd be some constancy over time in the gender mix, wouldn't you? You wouldn't expect that to change, but it's changed radically. The second thing we know about these teenagers is that they're very unwell. Very unwell. In the Royal Children's Hospital data, there's a study was published 2 or 3 years ago, which showed that 25% of the patients at the RCH and the gender service had eating disorders. So these are teenage girls, many of them with anorexia or bulimia. 45% were on the autism spectrum. Now, this is the same all over the world. The early Dutch studies, going back 15 years now, they recognized they had a massive overrepresentation of autistic children and young people in their group. So we know that there are those two characteristics. We know that these teenagers have a number of other mental health issues. They could be ADHD, it could be severe depression, it could be body dysmorphia, it could be a whole range of things, but they are very unwell. And no wonder that 10 years on, they're not doing well, because all the evidence is that the treatment with the puberty blockers or cross-sex hormones doesn't resolve those other mental health problems that they've got. No reason why it would do, because this is not a known treatment for these other mental health problems. So I think we've got a large cohort of young people who are finding an identification in being transgender, maybe a lot of status in being transgender, but who are very unwell and struggling with their identity, maybe socially awkward, as I say, autistic. So that's what we know a lot about. What we don't know a lot about is what the long term is, because all of this has happened so quickly. We've gone from 5, 10, a dozen patients in any one place through to hundreds, whether it's Melbourne or Brisbane or London or Amsterdam, the same thing. Clinics overwhelmed with all these young people who identify in some way as trans or as non-binary. And I think the longest follow-up study has been 6 years. So we know very little about what's going to happen down the track. And there's no point looking at the earlier studies, right? Back in 2002 or 5 or 10, because that was a different cohort of young people. That was these very, very small number of children who were being seen at gender clinics and given good psychotherapeutic support, mostly boys, and mostly having had this issue since they were very, very young children. Now we've got very significant numbers of teenagers who haven't had this history in childhood. They're just a different group, and we haven't followed them for more than about 6 years. Now, will some of them regret? Yes, but it's more complex than that. One of the big arguments is, well, what is the regret rate? And there are people who still claim it's only less than 1%. Well, that's nonsense. Absolute nonsense. There is a study which showed there was less than 1% who had gone through surgery as adults and then regretted it later. But that's old data, and that's people who've gone through right through to having genital surgeries. I think on average, the regret rate is about 8% at the moment, but I expect it to grow. There are some studies where they've looked at who was prescribed these medications and are they still on it 5 years later, and you get figures up to 25% when you look at the numbers who've gone off drugs in one American military study. So there's a general view that we just have no idea how many are regretting it, but it's certainly in the order of 8%. But I don't expect most people to regret it. Let me explain. These are young people who were desperate for the treatment. They were begging their parents. They were begging the doctors. They were threatening suicide in some cases. So there's a sunk cost. They made those choices and they live with them. And they may live with ill health. They may live with sexual dysfunction. They may live with all sorts of problems. And as they grow older, I'd be very confident, sadly, that their health problems will become more and more severe. But they made that choice and they live with that. So they may not detransition. They may think there is no way to detransition. I can't go back now. I was born a female, but I have a deep voice. I have, all these other changes to my body as a result of testosterone. It's too late to go back. So they may regret the treatment without detransitioning. And we simply don't know. But the more and more young people, young adults are coming out now in their 20s, regretting what happened. And I think that even more will do as they get up to the age of 28, 30, 33, when they're really seriously thinking about wanting a child. And, that wasn't an issue when they were 15. But as the biological clock ticks, women in particular, every woman will know and understand this. There is a part of them which really will yearn for a baby if they don't have one. And I expect that the worst is still well, I'm sure the worst is yet to come in terms of regret by people who were treated, say, 3, 4, 5 years ago.
Thank you, Professor Parkinson. The next question may be a glimmer of hope and common sense returning. I'm referring to the ruling by Justice Strum of the Family Court in about the last month it was, where he ruled against a mother who wanted to submit a child to treatment, gender treatment, and the father was at least uncertain, and the ruling, I believe, was in favour of the father, and the child was not permitted at the age he was to go ahead with the treatment. Do you think that is a significant ruling, and how would you explain that as the significance of that?
It's a hugely significant ruling. It's a case that I know well because I was involved at the early stages of talking with the father. He's a great man, absolutely wonderful father who's gone through hell, frankly, for many, many years, separated from his wife and enormous problems going back several years. This wasn't the first time they were in the family court. This has been a lot of issues before that, which led to conflict between them. And he took the view that let his son be who he is. Let his son explore these things. Let him be non-conventional as a boy. That's fine. Just let him be and see how he grows. And he was just concerned about blocking puberty, is what the mother wanted to do. The mother had taken him to the gender clinic first when he was 6. And at no stage before the case came on as a case in the court did the hospital actually make a diagnosis. This was one of the things that Justice Strum was very concerned about. It seemed like the diagnosis had been done for the purposes of the legal proceedings. And this is part of what I was saying to you at the beginning, that you move from a medical model. There's a thing called gender dysphoria, which is in the manual of mental health disorders, through to it's a human right. And simply kids know who they are, and we should affirm their identity. You see that shift, and there's no need for diagnosis. If you just say, well, this child is consistently trans, that's who they are, and therefore you just give them the treatment that they need and want. So that was one of the concerns that Justice Strum had, and he concluded in the end that the child didn't have gender dysphoria within the medical definition of that, that he was exploring his gender identity. And look, it takes all types to make a world. It takes all sorts of boys to be male. And we should be pigeonholing boys or girls into any one way of being a boy or one way of being a girl. And that was really what the father was saying, and the judge agreed. But the heart of his criticisms of the Royal Children's Hospital, and it's now been revealed that it was Dr. Telfer who was one of the witnesses. Dr. Telfer, who's been the leading figure in this area. At the heart of his concern was they could not explain their practice. That is, but Dr. Telfer and the other expert, who's not named, her name has not been revealed, but she's a senior clinical psychologist. They both gave evidence from the witness box that gender identity is innate and immutable, internal and immutable. It's not subject to external influences. You are what you are, and you can never change, which is the basis of these conversion therapy laws banning conversion therapy. But they couldn't explain why they believed that. They couldn't point to any empirical evidence that supported that. And Justice Strum made the point that, is there any other area where people don't change? Is there any other area of your identity or personality which is immutable? in that sort of way. And although they said, well, a child knows who they are. This is the constant line. The child knows who they are. We simply affirm who they are. They couldn't say at what age a child does know who they are, if you see what I'm saying. And they acknowledged, of course, well, it couldn't be when they're a baby. Babies don't know who they are. They discover it. Well, at what age do they have that capacity to understand who they are? Well, they couldn't give an answer to that. But they were both confident that this little boy at 6 years old knew who he was. And so the importance of Justice Strum's judgment, apart from the very serious and very strong criticisms he made of Dr. Telfer in particular, as an expert witness who was an advocate rather than an expert in his view, the biggest criticism he made was that they could not explain what they were doing at the clinic, why they were doing it. Now, if you believe that gender identity is innate and immutable, it cannot change, then there's some justification, you would think, in converting the body to fit with the gender identity. If it's changeable, if, as I have said, the majority of children we know from past studies grow out of it, resolve the issues by puberty, then it is scandalous to change, to irreversibly change their bodies when they may be going through a stage which resolves, or it may not. I acknowledge that. But we have no idea which kids will go on to be transgender adults and which kids will resolve their issues through puberty if we just, lovingly support them and let them be. And that is why I think Justice Strum's judgment is so important. He's a very fine judge. He's a very capable man, and the judgment is very carefully reasoned. The trial was 4 weeks long. There was an exhaustive exploration of all of these issues. And Justice Strum just quotes chapter and verse, quotes the evidence, feeds back what they said, what they had done, and concluded that it was unsafe to allow this child ever to return to the gender clinic. Now, the orders basically say that unless both parents agree, the child will not go back to the Royal Children's Hospital Gender Clinic. The father's not going to agree, so that's a hypothetical. But that's how strongly Justice Strum was critical of the Royal Children's Hospital. And I could elaborate more, but in a series of searing criticisms, he basically indicates, in my view, that the Royal Children's Hospital is not safe when it's dealing with children through its gender service, or that we cannot be confident that it is safe. So it's an important judgment, and it has certainly been widely read, not just in this country, but well beyond it. But the Royal Children's Hospital has just responded by saying, we're the world's best, nothing to see here. And that is, in my respectful view, grossly irresponsible. If a senior judge in a very well-considered and carefully written judgment, she took months to write, I might add, criticizes the chief of medicine so strongly, any responsible hospital would take note. I would expect the board to be instituting some sort of independent inquiry if the CEO hadn't done so. It's quite astonishing, if I may say so, that the Royal Children's Hospital has not in any way responded to this judgment other than saying, we're the world's best and we are world leading. That's what they said. We have a world leading service, is what they said. Well,
hubris.
a lot of hubris, but look, there's politicians who are full of hot air too. We live with that, but we cannot accept hubris when children's safety is at stake, and that's where the issue is.
Thank you, Professor.
We are starting to get a bit tight for time, Professor, but I'll just take one more question for you, and then one from Graeme, and then we'll hand over to our viewers, who I'm sure would have some for you. do we think, or do you think, I should say, we are beginning to see the light at the end of the tunnel of the transgender delusion?
Well, the first thing to say is it's not a delusion. That we must always remember that there are people who have genuinely had this problem, who do not have any other mental health issues, and who've held privileged positions in society, who have experienced this problem of being transgender. But as a movement, yes, taking over the schools and all those things, I think it is slowly but surely petering out. But a lot of people are invested in this. Hospitals and doctors will face massive lawsuits and negligence claims, and so the tendency is just to not admit they've ever made a mistake. So from that point of view, I don't think we're anywhere near the end. I think we're going to I think the advocacy groups will dig in, the doctors will dig in, the hospitals and governments will dig in. States like Victoria, which have so enthusiastically embraced this, will dig in until there's a change of government there. So yes, a bit of light, but we're not at the end of the tunnel.
Okay, thank you. And the last question from me is that you've also explained systematic reviews of the evidence conducted in several countries have all reached the same conclusion. The evidence of mental health benefits from these trans treatments is very weak, and some studies show no such benefits at all. Does this remind us of the old saying that error is halfway around the world before the truth gets his boots on?
Well, I think so. The studies have caught up with the practice that we should have had the studies first, then the practice afterwards, but it's gone the opposite way around. Just 10 days ago, another study was released in the United States in Los Angeles, led by a doctor in Los Angeles, very famous doctor. And it was a study of puberty blockers, which again found no mental health improvement in the cohort, having been on puberty blockers for 2 years. So yet another study by a leading transgender activist doctor and her team showing that there was no improvement. 28% of these kids were clinically depressed before they started on puberty blockers. A lot of them had anxiety, and 2 years on, there's no record of improvement. So there we are.
Thank you. So we'll take questions from our viewers now. So Peter, do you have any viewers putting questions to you so far?
I do, Andrew. So Professor, do you think there is any realistic chance that the current unfettered on-demand access to CSH for young adults over 18 will ever change? Now, you may want to start by telling us what CSH is, because I don't know.
Cross-sex hormones. So the question is a really important one. Of course, once you're 18, a lot of the constraints fall away. There's no need for parental agreement. And so a lot of the patients who go on to cross-sex hormones are young adults, and the parents often feel terribly powerless about doing anything about it. I don't think this is going to change until the lawsuits begin to happen and seriously high damages awards are awarded. There are 2 cases in Australia at the moment, one in New South Wales, one in Victoria, where these very unwell young adults were put on these treatments and then surgeries, and there's negligence claims against the doctors. I think this is the beginning of a large number, and sadly it will need the medical insurance companies to say we're no longer going to insure this before we'll see a serious change. The point with all these cases is that these were very unwell people, and they should not have been put on these powerful, life-changing drugs without a full exploration of what was going on in terms of their mental health, and that's been the real tragedy.
Thank you, Professor. Now, if your child tells you they think they are the opposite sex, how should the parent respond?
Calmly. and then go and get somebody's advice who's far more wise than I. I'm just a professor of law. But look, kids go through all sorts of stages, and sometimes, you know, they may say that on Monday and by Wednesday they've forgotten about it. So all sorts of things can happen with children, and, you know, being calm and unflappable and just say, oh, well, you know, that's interesting. Why do you think that? You know, or whatever, without making too much of a fuss about it at the start. I think would be very sensible. And let boys play with dolls. Let girls play with trucks. You know, don't get a hang up about what are boys' toys and girls' toys. I mean, that seems obvious, but we should let kids be kids, and they will develop as they will.
Yeah, thank you, Professor. Queensland has started an inquiry into the treatment of gender dysphoria. Is there much hope that there will be a sensible outcome from this inquiry?
Well, I certainly hope so. They're conducting the sort of study which should have been conducted. It's extraordinary to me. The Department of Health set up a review, which is the one that Dylan Wilson was talking about a year or two ago, and said, oh, you don't need to investigate whether the treatment's effective. Well, what on earth is the health department doing, setting up an inquiry of that time, of that kind? They didn't want to know the answer to that. The new government, well, not so new now, has set up a completely different review with an independent person, a prominent psychiatrist, and importantly, a psychiatrist who had no runs on the board, who had not expressed a view in favour of gender affirming care or against it, and a panel which I think is similar, that they haven't, you know, they haven't developed a position on the issues up until now, and that's wise, because you want people who will not be criticised as partisan, and I'm sure they'll do the sort of thorough study that these other countries have done, all reaching the same conclusion, that the evidence is weak. It's not non-existent, but it's very weak and should not be the basis of life-changing treatments.
Thank you, Professor. The last one I have is there any evidence that children are being influenced to claim gender dysphoria?
There's a lot of evidence for peer influence around gender identity. Now, gender identity is different from gender dysphoria. Just to explain that, when gender dysphoria is a medical diagnosis that this child, a young person or adult, is clinically distressed by the gap between their body and who they feel they are inside. And that's something needing mental health treatment because they are distressed by it. Gender identity, which is what people talk about a great deal, does not imply any distress at all. And it can be very fluid. They're non-binary one year and they're trans the next, and now then they're back to being female. You see a lot of fluidity and change, and it does seem to be happening in groups of friends quite a lot, particularly teenage girls, young teenage girls. The friendship group, one or two become trans, and then they join in. It's very popular to be non-binary. I have no idea what non-binary means. I don't think they have any idea what non-binary means. And this is truly a fad, which will pass. And look, if they think they're non-binary, and then when they're 14 and they grow out of it by the time they're 17, and they don't change their bodies or do anything radical, that's fine. That's fine. All of us who are parents know that the teenage years can be a little bit trying for the parents, and this is just another fad. But yes, it's clear the peer influence is there, and the trouble is if they then start going seriously down the track of wanting to alter their bodies in some irreversible way.
Thank you very much, Professor Parkinson. Over to you, Andrew.
Thank you. Just to finish off with you, Professor, I've got a question that I picked up from Kirralie Smith. You've probably heard of Kirralie. She runs the organization called Binary.
Mm.
And she wrote that it's not loving to lie, and you don't help someone by affirming a lie, and it is not violence or bullying to state the truth that men are not women. And later, no male can change his sex. No male is or can be a woman. Can the general public have any confidence in a scientist or a doctor who disagrees with her?
Well, plenty do. And what I always want to ask is, well, yes, but what do you mean by saying there's more than two sexes? And usually what they mean is something like there are a very small number of people born with intersex conditions, and they make that into somehow that there's not a sex binary. Well, we've always known children born with variations of all kinds. That doesn't mean that they're a different species, as it were,
Yep.
a different gender. So a lot of this is just language in terms of what doctors are saying. What I'd say in response to QLD's statement is, yes, you can't change sex. You can change sex traits. You can change your voice by taking testosterone. If you're female, you can cut off your breast. You can do these things. They modify the characteristics of sex, but they don't modify your sex as such. But how do we respond to people who do feel that way? I think always with respect and care. If it doesn't harm me in any way to affirm them with the identity that they have, there's no skin off my nose whether I call them he or she. I'll probably do that out of politeness. I won't argue with them. I had a colleague at UQ who came to see me, and we had the most respectful and decent conversation. She identified as non-binary. I probably shouldn't have used the word she. I guess she might have used the word they. But we were able to have a perfectly respectable, adult and friendly conversation without me criticizing her or challenging her on her non-binary identity. And I think that's the way to go. But there are times it really does matter. It matters enormously if men are going into girls' changing rooms and or participating in girls' sports. And then we have to stand up and say no. There are limits to the extent to which we can recognize you as being a gender other than your natal sex.
Thank you, Professor Parkinson, for your time with us today. We appreciate your professionalism and your care and your thoughtfulness towards children in particular who struggle with these matters, and I'm sure with the parents who are wrestling with the aspects of this debate that they find disturbing and challenging, while they're wanting to offer their best love for their child. So thank you so much for being with us today.
Pleasure. Thank you, Andrew.